Well, thanks everybody for being here. My name is Jamie Harvey. I am the CEO of Agilion. Agilion is a small technology and business consulting boutique. We help Medicaid organizations better understand their beneficiaries, support their health, and improve retention. And we do that by helping them understand their ecosystem data better. I'm going to be facilitating today. Originally, we had planned to have Thomas Mangrum join us. He's the co-president of Project Action and is an autism and IDD activist here in my community in Washington, D.C. Thomas wasn't able to join us today. He's not feeling well, but he and I designed this session together. And so the questions actually come from Thomas. There are questions that he had about the Medicaid system that he knew that the people that he advocates for do. And so I really wanted to give him the credit for a lot of the thinking that went into this, and thank Lorraine for introducing us to him. Like I said, I'm the CEO of Agilion. I'm a technologist by background. I got very interested in Medicaid during the implementation of the ACA that I worked on, and it's a real privilege to get to convene this group. I'm just going to go around and ask folks to do a short introduction. I'll go in the order that it's listed in my program, which is Stephen, if you could go first, that would be great.
Sure. First of all, thanks everybody for taking the time to be with us today. My name is Stephen Marin. I'm a physician by training, actually a pediatrician by training. Although I do not practice pediatrics, I spent the last 25 or so years in various levels of physician leadership in organizations on both sides of the health system equation. I've worked for two large health plans. I've been a hospital executive, the chief medical officer of a national primary care practice, and the chief medical officer of a national autism services provider on one side. And on the other side, I was the medical director for both a commercial health plan and a Medicaid managed care plan, and a small plan that exclusively served people with IDD. So it's been interesting from my perspective to be on both sides of that divide. We're going to talk a little bit about how that relationship has evolved and where we can take it in a few minutes.
Fantastic. Kristen, if you could come off mute and introduce yourself, that would be great.
Absolutely. Hi, everyone. My name is Kristen Parker. I'm delighted to be here as both a healthcare leader and an advocate for families navigating the complexities of Medicaid. I currently serve as the Senior Director of Growth for Fidelis Care New Jersey, where I lead efforts in healthcare strategy and Medicaid growth. I've been in the healthcare industry for about 15 years, and I focused much of my career on improving access to care for vulnerable populations, including families with children on the autism spectrum. In addition to my professional background, I bring a personal perspective to this discussion. I am a person on the autism spectrum and the proud parent of a young autistic woman. My lived experience combined with my professional expertise has given me a unique understanding of these challenges that families face. I hold a strong passion for healthcare improvement with a particular focus on reducing barriers to access to care for Medicaid members. So thank you, Jamie, for having this session today.
Thank you. And Lorraine.
Great. Thank you. Thanks, everyone, for joining us today. My name is Laureen Reagan, and I am celebrating my 40th year in the developmental disabilities community as a clinician and administrator. I spent 20 years with the New Hampshire Department of Health and Human Services and ultimately served as the Bureau Chief for IDD Services there. I retired in 2017 and then spent 4 years with Mercer Consulting. I was a principal in the firm and had the pleasure of working with a number of Medicaid programs around the country. I then spent 2 years with Intellectability, a health technology company, as the director of public relations, and I am now a strategic consultant to Intellectability. Thanks so much.
Fantastic. So I'm just going to jump right into the questions. Families with children and adolescents in Medicaid want to understand the process for when claims get denied. Like if a doctor says that you need something, certain care, prescriptions, equipment, why is it that sometimes Medicaid or the plan says no to that? And can you give us could you give folks some insight into how that works and what the tensions are there? Stephen, I think we said
Sure.
we'd pitch this to you first.
Yeah, no problem. Well, first of all, I just want to say that A lot of this can be described in an article that appeared in this week's New England Journal of Medicine entitled "The Failing U.S. Health System." And one of the problems that is cited in this piece, which is really excellent, that again, that's coming out from within the medical community, is some of the misaligned incentives in terms of actually improving people's health. Again, having been in a health plan, I understand that most health plan policies and procedures are developed based upon averages. If you have a population of 100,000 people, you want to see what the averages are across that population, what the average conditions are, what the average risk factors are, what the average utilization patterns are across that population. And then you make your policies based on averages, because health plans are, by their very nature, actuarially based. It's a statistical analysis of the needs across the population. And by the way, fundamentally, there's nothing wrong with that. But the challenge becomes when you have smaller groups that have unique sets of risks and conditions in which there need to be some accommodations for their care. So the autistic community and the IDD community tends to be single-digit proportions of those populations. It's 1 to 2 to 5% of the population. And most plans that I've worked for, again, one large commercial plan, one large Medicaid plan, and a small dual eligible plan, most of the times those plans say, I cannot change my entire set of policies for such a small cohort. What they don't realize in general is that those small cohorts have a disproportionately large influence on the performance of the plan. And so while their policies are based on population averages, they don't necessarily understand the need for these accommodations, nor, by the way, how those accommodations can add value, not just to the patients they're taking care of or the members they're taking care of, but for the actual plan itself. And there's a great example of this is, by and large, in a large cohort for a health plan, the risk of osteoporosis, bone density problems, is largely accumulated in women of a certain age. So the quality standard for most populations is women who reach a certain age get screened for bone density. What they also don't necessarily accommodate is the fact that anyone who uses alternative ways of mobility, like a wheelchair, who also have risks for bone density. And the risk of fracture in that population is just as high as it is for the risk of women of a certain age. And yet, again, we don't necessarily build that in. So the decision as to how these denials take place are based upon criteria called medical necessity. You'd think that doctors, I'm one, you'd think that I should be able to make the determination as to what's medically necessary. But again, health plans have to manage the costs associated with patients. And by the way, most health plans get a fixed amount of what are called premium, or amount of resources available for any one of the members in the plan. They have to manage that for the best interest of the plan as a whole. But again, part of what we want to advocate for here is what we call population tailored, or autism tailored, or IDD tailored care, and the implementation of policies in which those medical necessity criteria accommodate or account for some of the needs of these smaller cohorts that really becomes critically important to their long-term health and life course health to be able to make those accommodations.
So I'd love to open it up to the other panelists. So in terms of what have you folks seen that you think that we should be advocating for this population in particular? Because it's sort of a bigger problem there of that getting this incentive set up right for edge cases, but no people want to be treated like they're an edge case, right? Like, so Kristen, like what do you see in this area?
Yeah, thank you, Jamie. I think that one of the things that the drum that I consistently beat is the importance of helping families learn the significance of family-centered care coordination, because a lot of the times the folks making these decisions are they don't see the child directly, and that can already feel incredibly impersonal. They rely on documentation and evidence supported or submitted by the doctor, and if something's missing or if it doesn't meet that specific wording or criteria, like Steve was talking about, the claim may be denied. But I think one of the good things that we can work with these families on is that there are pathways to appeal, and there are ways that you can continue to advocate for yourself and your family. And sometimes it's just about ensuring the doctor's document or the provider's documentation is aligned with Medicaid criteria. And other times it's just about persistence, appealing the decision and submitting, the different evidence and clarification that's needed. So yeah, it really just is about helping these families advocate for themselves.
Lorraine?
So this question was really interesting to me. One of the things I meant to mention during my intro is that I took a short hiatus, a 2-year hiatus from state service to work at a managed care plan based in Boston and also in New Hampshire. And one of the things that was, I think, not well understood in in particular when we're talking about children, I think this is really important to remind others that under, children on CHIP or Medicaid have access to services through EPSDT, or early periodic screening, diagnostics, and treatment. And there's really, and that's a very large umbrella, right? It includes things like private duty nursing that are often controversial, and either, there's often, attempts to limit that or not approve that under certain circumstances, or other things that might be requested by a family. ABA, for example, for many, many years, states had ABA, applied behavior analysis services in their children's waivers, or available to children under a waiver. And CMS required states to pull those services from their waiver because they're not optional services like other waiver services. They are an entitlement under Medicaid. And so I think really helping, physicians, plans, others to understand that in many cases, denials for children's services under the Medicaid state plan may be inappropriate under EPSDT.
Mm-hmm. So that's great. So Thomas's next question was about folks and children and adolescents with IDDs and autism. Sometimes folks need more time with their doctors, and so actually I'm gonna go off script a little bit. At the plan that we work at, where we work with a specialized plan for disabled children, like everybody gets care coordination. Everybody gets assigned a care manager at that plan. In general, I'm wondering, like, with kids that have been diagnosed with autism, do they get a care manager in most places? Are there standards around that? And how does that fit into this?
Take it here from perspective in 2 states. It's extremely variable, and
okay.
some of it has to do with other criteria. So, for example, so the plans themselves may have what are typically called tiered approaches to care management assignment, with different levels of care management depending on, again, the criteria that's set by the plan. Very often those criteria have to do with, again, chronic illness, utilization patterns, and other risk patterns. They don't necessarily have to do with functional status, which is, again, one of those really important aspects of providing tailored care to the IDD and autism population to begin to factor in. You can have, and I'll give an analogy for people who are listening who come from the health plan side. You can have 2 patients with congestive heart failure that have completely different functional classes. And their needs are not based on their ICD-10 code. They're based on their functional status. That model very easily can be moved over into the disability space, because, as we know, you've met one person with autism and you've met one person with autism. Right. Kristen, I'm glad you got that. Thank you. But I will tell you, there are other places where there is more a disciplined assignment. In New York State, for example, the Office of People with Developmental Disabilities has a mandatory care management program for people who meet the eligibility criteria for OPWDD. That's not waiver services. That's a state-based program. But again, they've set that bar at a certain level of disability. You either need a certain level of limitations in your functional skills, or you reach a certain IQ threshold. and you're eligible, but then everybody must have one before they get any of the home and community-based services. So, and there's other states around the country. North Carolina has a great program now in IDD and severe mental health, tailored care. Florida just launched a demonstration project for IDD managed care, in which every member will be assigned a care manager, and it's an intensive care management model. And clearly, Jamie, as you mentioned, for populations that need the support, need navigation. Their lives are significantly more complicated. It's not just health issues that need, we're not just coordinating healthcare. You have to coordinate the person-centered care that goes along with that.
That leads well into another question, which is that children and adolescents with autism on Medicaid often have complex issues, right? And so they might have medications that interact with each other. They might have transportation issues. They might have different doctors who don't know everything. So Lorraine, can you speak a little bit to how plans manage complex care for children with IDD and what's important there?
Sure, of course. So I think probably tagging on what Steve said, there's a lot of variability, right? One of the challenges, I think, is that I'm not sure that children, especially younger children with autism, are going to be fed into the risk stratification algorithms that exist, because they're pretty traditional, right? They're based on claims, right? And often you're looking at people with certain claims, a certain level of claims, and maybe looking at other things. I think that plans would do well to add autism, so just based on the diagnosis, right, to their risk stratification algorithm, so that you are capturing the children. Because one of the things that I think about a lot is often, we may have some claims data, we may have some information about children, but especially given that they're so much younger, and because often parents are doing such a great job supporting their children, they're not ending up in the emergency room necessarily. They're not at urgent care. They're not necessarily having a history. They don't necessarily have a history of hospitalization, but when things happen, they tend to be profound, right? So if they haven't been pre-identified in some way, I'm suggesting that one way might be by having a tag for children with autism. In some states, in the state where in the two plans that I worked at, anyone who was on a waiver, which again is certainly not all children with autism, had a widget on their record that showed that they were receiving waiver services, and that was a signal that they may need care management, or that if they or their family call the plan, that they might need to be connected with somebody that's got more experience around complex case management.
And just to piggyback on that a little bit, Jamie, I think that, when we're talking about children, we're not just talking about like children, we're also talking about adolescents, right? And as children kind of age into, their themselves with this diagnosis, I think as health plans, we have a real opportunity to partner with providers who specialize in IDD, who may have, extended appointments for children with IDD, or may have an enhanced experience in perhaps a teenager who may be able to advocate for themselves. I know that is a huge like kind of stepping stone for a lot of autistic children to be able to say like, hey, this is what I need, and advocate for themselves. But I think health plans can support families through advocacy and just knowing what's out there as far as resources. I know when my family started down this journey, we had no idea, where to go. And just ensuring that folks know their rights and options when it comes to accessing care, as well as like educational resources about how to navigate the healthcare system, because as we know, it is incredibly complex, and especially complex for families that may or may not have special needs children.
And there's an excellent South Park episode about navigating the American healthcare issue that I do
yes
check out. It's good, especially the song. As we think about and I love that you brought up the adolescents, because as we think about children with autism and their life courses, like part of what is going on, and I've got kids with IDD issues. There's you want to support them, but they also need to advocate for themselves. So I'd love to have a conversation about how health plans and healthcare systems can better support children with autism and their families as they transition from pediatric to adolescent to the adult care world. And Chris, I'm going to open it back up to you because you had talked about your experience with that, and I'd love for you to go back to that.
Yeah, absolutely. And I don't I apologize for this, Jamie, but I'm going to regress a little bit. But one of the things Steve mentioned was that, you know, if you know one person with autism, you know one person with autism. I would even say, like in Medicaid, you know, if you know one state, you know one state, right? Like especially when it comes to the offerings that they may have for special needs families. And I think one of the things that we are really prioritizing as part of the work that we're doing with our state partners is establishing is really understanding like how to establish those specialized care coordination programs and having that central point of contact that understands the needs of IDD persons can significantly help ease the burden on families and ensure that doctors are informed. To Lorraine's point about the widget, I think that's a great idea.
You know, we had a conversation the other day about the way that autism can overshadow diagnosis and how unconscious bias can play into that. You know, uh, autistic kids are already at least twice marginalized because they're a kid, and you know, and then they're dealing with the biases around autism. We have a consultant at Agillion that was here for our practice session for this, and they talked about how they, as a young person on Medicaid with autism, you know, felt disenfranchised by the system, right? So I would love to hear your guys' thoughts about what's working and not working around that, and where we need to do better.
Let me I just want to reinforce something that Lorraine said earlier, because that directly ties to what you said, which is, and I've had conversations with a number of large health systems in terms of their risk-based contracts, that their population health groups, and I've asked them, do you segment out? Do you actually do analytics and segment out your kids with autism? Do you segment out your adults with IDD? The answer was no, and the answer was no, we don't know how. Because it's not always, again, it's not always the ICD-10 code. There's other things you need to look at. This is important and critically important. And it's important, again, not necessarily just for the autistic and IDD community. It's important because there are a number of population-based cohorts that need this level of accommodation and consideration. And Jamie, you mentioned it. I know Elsie said it last time we were talking, with their experience as an autistic woman and who came to the diagnosis late in life, who also at various times in their life had been on Medicaid. It's very easy sometimes in those situations where you're going in for care to something that you're talking about, some experience you're having, being attributed to your autism. And we call that overshadowing. Whatever it is you have is overshadowed by that primary diagnosis, that identity-based diagnosis that you're carrying with you. And the idea of knowing who those people are in the population is a way actually to, whether it's a widget or a flag, the flag says this is a situation where you need to be very conscious of your unconscious bias. You need to be aware of the fact that you will have, and as across the population, it's not an individual thing. We know this in large cohorts in clinical practice. You are more likely to overshadow, and therefore you need to be more considerate and provide more validity to the story you're being told, the narrative that's coming from your patient, and find other alternatives. One of the phrases we use with the autistic community is all behavior is communication. And I know Lorraine's team at Inelectability does a lot of work in this regard, because there are very serious medical issues, whether they're dental or gastrointestinal or others, that can often generate behavior that mimics or appears to be associated with that identity-based diagnosis. And that's a serious problem. And let me just take 2 seconds and talk a little bit about that issue, because you asked about transition to adulthood.
Yeah.
The handoff, and Kristen will appreciate this, as may you, Jamie. People will stay with their pediatrician until they're in their 20s, because there's no, you look around and you're trying to find an on-ramp for your child, an on-ramp into the adult healthcare world and there is no formal on-ramp. So part of what Medicaid plans can do tangibly tomorrow is to begin to say, we own the provider, we have a provider relations team, we own this population, we've got contracts with them. How can we design on-ramps for the children in our plan to responsible parties who are willing to raise their hand and say, okay, I'm willing to take on the responsibility for autism tailored care with that cohort.
Lorena, I would love to invite you to talk about the work you've done around this and that your company's doing.
Sure. There's really two things that I think about, and really to tag on what Steve was talking about, the issue of diagnostic overshadowing, in particular for children with autism who may present to a clinician in some ways that might be very different, right, than other children, is really critical because it is one of the primary factors that drives the health inequities that people with IDD are suffering. And they are not only affecting quality of life for people with IDD, but they are also putting them at risk for morbidity and mortality at a much higher rate than others. And so when we think about the diagnostic overshadowing, and one example that I mentioned when we met recently was a pretty well publicized story about just a little boy with autism who was brought to the doctors. He wasn't well. His mother made it clear that he hadn't been well. His activity level was much lower than it typically was. There wasn't anything really specific, but mom brings the child to a clinician. The clinician says, well, this is really just autism or something else. And the child died of sepsis shortly thereafter. And so really thinking about, what does all of this mean, and thinking about how clinicians can really drive, right, standard of care, and remembering that obviously this was an ill visit, but the other thing that I think we don't always think about is that all children, there's a periodicity schedule for everything for children's clinical health supports, right? And so children with autism need to follow that same schedule. And then they may also have things in addition that might need to be explored, celiac, seizures, different things, right, that may be happening with the child. And then the only other thing I would add is that this should be an area of interest for all providers and all payers, because when we fail to address the acute health issues for people with IDD, what we see over time is decreased function, an increased need for long-term supports and services, poorer outcomes, etc. And so whether you're on the physical health side of this, the behavioral health side of this, the state plan side, the waiver side, everything comes together and really culminates in a recognition that the care and supports that we're providing today are not adequate, and they are very costly, and also resulting in poor outcomes. And Inelectability does a huge amount of work around risk identification, health risk identification, and also to this specific issue, educating clinicians through a curriculum that was developed by Dr. Craig Escuday that's available to all clinicians to recognize and understand how to provide health care for people with IDD.
Fantastic. Thank you for that. If there are folks in the audience that have questions, if you're comfortable putting them in the chat, I'm going to try and get to some of the questions. And in the meantime, though, I'm going to kind of do a round robin and ask each panelist to share any finishing thoughts before we have questions. With sort of the prompt of like, what should people in the Medicaid space focus on around thinking about kids with autism and their better care outcomes for them?
Last words?
Last word, yeah.
Okay. I'll go first. Again, having been at health plans, I know that sometimes these kinds of conversations can look as if they're an imposition of change, or an imposition of extra work, or an imposition of some burden that's required on the business side of things. Having done this, though, I can tell you that it's not, and there's tremendous benefit to plans to take the effort to begin to look at some of the ways that you can improve the care of your members through very specialized and tailored efforts. For example, whether it's an annual wellness visit or a preventive services plan, there are distinctive risks in the IDD community, for example, distinctive risks in the autistic community that can be easily accounted for with a preventive services plan. The second or third most common reason for hospitalization for an adult with IDD is aspiration pneumonia. So therefore, let's try to add a choking risk assessment to our incentives for annual health risk assessments for that population.
Right.
And now you've done exactly what the mission of Medicaid is upstream prevention. So it's really a matter of saying, okay, how can we identify some of them? Lorene mentioned the work that Inelectability does. There's a number of ways that standards and practices could be evolved from the work that Inelectability does. There's other measures. I'm working with that demonstration project in Florida. We're actually doing webinars for the provider community on IDD tailored care. These are low cost ways of informing the clinical population as to what some of these again distinctive ways that you can do some upstream interventions and prevent really preventive exacerbations, prevent risk, and understand some of the unique risks of that community.
I'll go next, Jamie. I just wanted to say that I think that the health plans have a unique responsibility to the IDD community to keep an eye on and reduce as it is possible Medicaid churn, specifically for some of these populations that may or may not have medically fragile persons. And one of the things that I see time and time again is, we will have folks that kind of are in and out of Medicaid. And I can tell you that the PHE unwinding recently has shown an enormous light on some of the inequities and some of the process challenges that we have around ensuring continuity of care for this population and all others, right? So I think that there's a lot of onus on the health plans to make sure that there is a partnership with our state partners to ensure continuity of care and reduce churn.
Great. Both great from both of you guys, great suggestions. I have really three main things that I would say. And really the first is listen to children and young people and their families. They are the experts on their health care. Really start watching early and really, I think, be very, very careful with polypharmacy. It's not unusual to see medications added on and on and on. And oftentimes, I know this to be true. Psychotropic medications are ordered for things that are not psychiatric issues or challenges. They may be something else. And then really make sure that families have a choice of services, particularly as we think about for younger children, but also adolescents. Not every family is going to want the same modality. Some families will gravitate towards, based on their children's sort of needs, will gravitate towards acquired, ABA. Applied behavior analysis. Others might want floor time. Others might want hydrotherapy. Listen to families and work with them on the modality that they think is most likely to reach their child and provide that to them and evaluate it. Take a look at the outcomes.
Just want to piggyback on something Lorene said, which is health plans are in a position to share medication lists because they have the only master list of every medication a person is on. We discovered this, we understood this in our IDD focused health plan in New York. And we began to actually send medication reports because you may have a patient who goes to an urgent care center and is never going to show up in your EHR. And there may be medications added in hospitals at transitions of care. And I think that plans really have an obligation to share those lists with primary care because there's a unique view of the patient that health plans have that no one else has on the planet.
Just rewinding for a second, something Lorene said, I really wanted to hit it because Thomas, when we were having this conversation, he was talking about how many medications get stacked up on each other. And he reported that it was a very bad problem in the community where folks were being prescribed stuff that was essentially designed not to deal with their illness, but to make them go to sleep, like to make them easier to manage, right? And that is as an advocate, he wanted to have it heard, like what a big problem that was. So Lorraine, I'm glad you hit that. You are speaking exactly to what he was wanting to shine a light on. So I really appreciate that. We're at our time. I didn't see any questions come across, but I'm not exactly a Zoom webinar expert yet. So hope everybody got their questions answered. Thank you all for being here today. I learned a lot in all these conversations, really, and I'm sure our attendees did too. If anybody is interested in having a conversation about solving that problem Stephen was talking about of how to figure out the data problems with this, that's what Agilion does. We help Medicaid Ecosystem companies with their hardest data problems, and especially with figuring out how to deal with those churn problems that Kristen was talking about. So thank you everybody for joining us. It's really a privilege to get to convene this group today, and we will be in touch.
Thank you.
Thanks.
Thanks, everyone.
Thank you.